So today, the real theme today obviously is these pediatric treated injuries, but the basis behind this is because, as we saw with Dr. Person's talk to start, with this new cultural change to sport specialization, it's led to a significant increase in the load on children through these sporting activities. And it really requires us as practitioners to better understand how they get injured. And part of what you're seeing through today is it's not the same way as how adults get injured. So I am a sports and exercise medicine physician as well as a full-time emergency physician. I do have one disclosure, that's just that I'm the director of a medical device company that's unrelated to today's conference, but there's no other financial relationships and no other industry relationships to disclose. So the first part today in terms of this talk is I want to be able to explain the terminology of pediatric bone injuries. And that's to give you a better understanding of what you as a clinician can look for when these child athletes come into your practice, but also give you a better approach how to work them up. Secondly, if you don't remember anything else from my talk today, is to demonstrate an approach to specifically apophyseal injuries. And if you don't know what an apophysis is, I hope at least you'll take home what an apophysis is after this talk. And finally, to describe pediatric bone anatomy guides to guide your diagnosis. So one of the first things that comes up, and we talked about defining concussion earlier. Other things that have been difficult to define in sports medicine include sports hernia, but in the pediatric realm, one of the terms that comes up is osteochondrosis, or the plural osteochondroses. And if you've ever heard this term and you've been somewhat confused as to what exactly that means, you're not alone. If you take a look in terms of how it's been defined in the literature, it's quite variable to being kind of very vague in referring any kind of bone injury in childhood to specifically the joint or the epiphysis. And this is like some of your top references that you're looking at. So whether you're going to UpToDate, Radiopedia, American Family Physician, it's quite a varied definition. And in fact, if you go deeper into the literature, most of the reference to osteochondrosis is in the veterinary literature, but it encounters essentially a multitude of diagnoses, making this term somewhat unhelpful. So it can include, in terms according to the literature, it can include anything from apophysitis to a vascular necrosis, to a skiffy, to osteochondritis dissecans. So I'm proposing that we kind of get away from using this term, as it's not in any way helpful for us when we have a child athlete in front of us. The other issue that this creates is from a research perspective. So, we have a number of bone changes that are going on through the ages that are occurring at different ages depending on the child. So that a child may have growth plates closing at age 11 at a particular bone, and in another child it might be 16. So how we define these things is very important. And then finally, the terminology. If we can't essentially specifically define the terminology, we're going to have differences between different studies referring to the same term but in different ways. So I think it's important that we consider reverting back to an anatomy-based classification. The second thing is that many common pediatric bone-related injuries can mimic bone tumors. And this is something that you want to be aware of, because apophysitis injuries are something that's going to come to you as a presentation in your clinic. And when they are looked at different stages, they can have an appearance that doesn't look like normal bone. And so if you're aware of that as a clinician, that can help you essentially guide further imaging or further advice to the patient. Finally, the lack of clarification of the terminology is leading to some of these inaccurate epidemiological findings of the pediatric population, and we're going to take a look at that in a second. So the first question is, you've got a kid less than 14. What do you think the probability of them having a tendinitis is? Do you think it's 5% of injuries in that population, 20%, 50%, 75%? There's a number up there, but I'm going to tell you why that's not correct. Anybody have an idea? Okay, so in one of these studies, it looked at the U14 population as having approximately 9% of injuries related to tendinopathy. And now the question I have is this a mixed characterization of the injury as a tendon issue as opposed to an apophyseal injury? And the reason why is if we go take a look further, we take a look at larger studies, and this is a study that looked at 43 different studies specifically in soccer players from U12 to U19. And when you actually take a look into the study material, they actually compared pediatric males to adult females to essentially determine. So there's an amalgamation, and there's two problems with that, as we'll see later. One is that the male bones actually are slower to close in terms of growth plates than female bones, and therefore you're actually comparing what are truly adult-like injuries in that female population to pediatric injuries. So it's not really a good, essentially, comparison between male and female athletes from an injury population. The second thing is this is a demonstration. This is from the American Journal of Rheumatology. So this is 2012. This isn't that long ago. And you see here that they refer to two different parts of a femur as the epiphysis. They talk as one where the arrow is as the traction epiphysis, okay? And the second one is in the joint. Let me just see if I can confirm this on here. So they're referring here, just above the greater trochanter here as the traction epiphysis, and they're pointing here as the femoral head or the femoral epiphysis as the compression epiphysis. So they're using the term epiphysis to describe two different areas. And this is where the clarification of these terms is going to be very, very helpful for you as a clinician when you're reviewing both the athlete and their imaging. So this is going back to the basics. So when we take a look at pediatric x-ray, the areas that you want to be taking a look at are starting with red. You're looking at the epiphysis, which is the end of the bone that is forming a joint. Okay? That's connected to the rest of the bone by the physis, which is the growth plate. And then that part is connected by the metaphysis in green to the diaphysis, which is labeled down here, but it's also essentially the shaft of the bone. As opposed to referring to these other bumps that we have, so for example, greater trochanters or tibial tuberosities, here are medial epicondyles, as opposed to referring to them as traction epiphysis, these are called apophyses. These are very, very important, and especially in understanding childhood sporting injuries, because as you continue to increase their hours in sports specialization, this is the area that gets pulled on, and this is the area that tends to get tender. So everybody here has probably heard of the Osgood-Schlatters. That is probably the commonest and most known apophysitis. Okay? It's important to understand these because this is the difference between a traction injury and a compression injury. So when we take a look at the categorization of the pediatric bone-related injuries, I want you to keep those different areas in mind because when you're examining the child, these are all palpable and it gives you a better idea of where you might be looking for an injury. And secondly, if you do get imaging such as a radiograph, it's going to give you an idea as to where to look on the imaging for a particular injury. So when we take a look at the first chart, if you want to use the term osteochondrosis, I would limit it to epiphyseal injuries. So the epiphyseal injuries, these are your compression injuries, sometimes idiopathic, but these are referring to that part of the bone that articulates within other joints. The epiphysis at the end, so if you think of our femoral head in that previous image, this is where you can get your avascular necrosis, your osteochondrosis dissecans, which we commonly see from the sports medicine perspective in the knee, elbow, and ankle. Extremely rare, you get it in the humeral head as well, but those are the common areas. And then there's other locations that you can get avascular necrosis in, and I'm just going to demonstrate a case next year. This is a 5-year-old male that came into the emergency department unable to weight bear on the right foot. They had an x-ray which was reported as normal, and they were brought back specifically to see me for a second opinion. And you can take a look based on just the image alone. When you take a look at the left foot versus the right foot, it's hard to make out, but you can tell that there's swelling because the right foot looks larger, but there's a swelling over the dorsal aspect of the right forefoot. So the first thing I did is I took a look back at the x-rays that were done. So when we take a look at the x-rays, and this is where this anatomical classification is going to be much more helpful than using kind of fancy terms. So when we take a look at the bones, first thing we want to take a look at is look at where the swelling is. So we take a look at where the swelling is over the dorsum of the foot, okay? And now let's take a look inside this area. So if we take a look at the talus, okay, the cortex looks intact. The navicular bone, so this is the talar navicular joint here. You can see the navicular bone here. First thing you notice is that this bone looks different than all the other bones. What's different about it? Anybody apart from Dr. Steiner? So does it have the same volume as the other bones? Okay. Does the bone marrow look the same? Okay. So the first thing you might notice is that when we take a look here, that navicular bone is more white, so it's more radiopaque than the surrounding bones. The reason why that's happening is because the bone has compressed. Okay. The reason why that bone is compressed is because of avascular necrosis. Okay. And if you don't believe me, you can ask your foot and ankle surgeon when they follow the patient up to do you a favor and ask them to get bilateral x-rays so you can show that with permission of the patient for the case study. So this is what a normal navicular looks like on the left. Remember that left foot that had no swelling? Okay, I'm just going to move that slightly over. So this is the navicular bone here, and that's what it should look like. So it's got a volume to it. The bone marrow has the same consistency as the adjacent bones, okay? And you can see it here in the middle with the bilateral x-ray. Now it's hard to see on this AP where I put the arrow, but when we take a look at the right lateral, now you can clearly see compared to the left foot, the difference of that bone. Now, this is an example of a compression injury, and a compression injury will typically affect your epiphyseal part of childhood bones. The childhood bones are very vascular. Even though when we knock on things, it's very hard, they're in a significant state of metabolism regularly, and therefore they're quite fragile to these compressive injuries. So in terms of osteochondrosis, going back to why this term is not really appropriate to give out to all bony injuries, one is just from the Latin basis. Secondly, it really should involve the bone and the cartilage injury, and that's why I'm recommending that we just use it specifically for epiphyseal injuries. In terms of the pathology of these epiphyseal injuries, so because the blood supply is fragile and the bone is softer in a developing epiphysis, you can get essentially a disruption of that blood supply, which leads to essentially an infarction of the epiphysis and then fragmentation and breakdown. It should hopefully, with protection, reossify with further osteoblastic activity. And then specifically, this is for Perthes, which is a little bit of an older age group than the previous case with the avascular necrosis of the navicular bone. But the remodeling of Perthes can happen in about 2 to 4 years. In the previous case with the navicular bone, we don't actually have good literature as to what the natural history of that is. This child was up and running within 2 to 4 weeks, which goes back to previous talks where we were talking about, when Dr. Wynn was talking about how do you shut a child down from activity, they'll kind of get back to their activity as they can tolerate, regardless of your instruction. So the younger the age group, the better their ability to heal and less requirement for intervention. This is by far the most important category, and we're going to talk about why shortly, but these are your apophysis injuries. So when you're seeing children, especially under the age of 14, and they're doing a lot of physical activity, and they're coming in with a muscle strain, thigh strain, perhaps it's a heel strain, I want you guys to first think about, one, the location of where this is bothering the child, and if it's any way proximal to a bone, I want you to think of apophysis, and almost always it's going to be proximal or near to a bone. Okay, and that's because the tendinous structures in children tend to be stronger from a physics perspective than the actual growing bone. So the apophysis, it's a very important piece for the growing bone. So when we continue to do activity, we think about, for example, Osgood Schlatters, and we're jumping and we're landing. Every time we land, that's a braking force that is pulling on the tibial-tuberosity. That's promoting osteoblastic activity, which is promoting that bone to grow in relation to physical activity. That's why we tend to get these bony bumps that are worse in jumping sports from all the landing. So it's actually a good thing to have these apophyses. This is why it allows us to grow based on the activity we're doing as children. However, they can lead to issues. So they can lead to pain situations, either acutely, so you can get an avulsion fracture, so an avulsion fracture of apophysis, or more chronically, which is more common, and this is where people get confused with the tendinopathies, you get a chronic apophysitis. So the chronic pulling from the landing, for example, in a basketball player at age 14 will lead to an Osgood Schlatters or a tibial apophysitis. Okay. Now, acutely, if you take imaging of these patients and you're concerned, they say the child comes in and they report a pop, you can take a picture. Okay, so you take an X-ray and you may see an avulsion fracture. This is more common, for example, in and around the pelvis. Now, interestingly, you may also see a separation in a chronic athlete, so somebody that's had maybe 3 months of anterior hip pain over their anterior cervicular spine. The difference there is the history, and that's why it's very important to understand, did this acutely happen, like you felt the pop and that was the injury, or has this been going on for several weeks to months? Because you can get essentially a separation even in the chronic apophysitis, and it really changes how you're going to manage that as well. Now, so everybody knows about, for example, the tibial tuberosity apophysitis is an Osgood Schlatters, but there are a multitude of apophyses around the pelvis and hip, and this is very, very important to understand when any of your running athletes, soccer athletes, figure skating, these are all sports whereby you can get these avulsion fractures of the apophyses around the pelvis. So your anterior superior spine, which is marked in red, is where your sartorius attaches. That can pop off, or it can mostly be chronic apophysitis, where your rectus femoris originates off your anterior inferior spine, which is right above the hip. So these are patients that might present with hip groin pain. Now, these are palpable on kids. You can push down and you can reproduce their pain locally, and they will not necessarily have any change in the range of motion of their hip. So they have a clear hip examination apart from when you palpate the actual front part of the pelvis there. So there's ways to differentiate these clinically. Your iliac crest. So for those of you that do pediatrics and you're looking at scoliosis, you may know about Risser's lines, which is the physis that goes around the top of the iliac crest rim, what we use to essentially assess how far along the growth is in children with scoliosis. That is an apophysis, and you can avulse that. So you can avulse that either from your iliac psoas, the iliacus pulling it off, or from your oblique, which you'll see in cross-country runners. So you can get a chronic apophysitis with those. The knee ones, the commonest one is Osgood-Schlatter's. In a younger patient, you can get ascending Larsen-Johansson, which is the distal pole of the patella. That's going to present differently than your patellar sleeve avulsion that Dr. Slimek talked about before, in that that's going to present more chronically, and it's going to be just really point tender over that distal pole of the patella. And then specifically in the foot, there is the commonest one, which is Seaver's disease, which is a apophysitis of the posterior calcaneus. Very, very common, especially in the ages of like 7 to 11. And it will be tendered specifically over when you palpate the back of the calcaneus. Okay, and then the other one is an Iceland's disease, or fifth metatarsal, where the perineal tendon attaches onto the fifth metatarsal. These are all easily, apart from the lesser trochanter, you can physically examine each one of these bony protrusions, and you can, for the most part, avoid having to do any imaging in the chronic cases. If you're more interested in this concern for the family, you can do a simple set of radiographs, and you can often see a change in the affected area. So, I just have a series of images here just to show a couple of points. And first one here on the where the laser point is, so the top left. These are often read normally by community radiologists, and part of the issue is this is why we have this conversation. This is a gap in knowledge in our care of patients, specifically the pediatric population. The top left, what we're taking a look at is the injuries on the left side. This athlete called a pop. You can see the lesser trochanter here. This is the one you can't actually palpate. This is where your psoas muscle inserts. On the left-hand side, you can see that it is a avulsed. Okay? Now, I'm going to highlight this because that's an acute injury. If you were to see this athlete at, let's say, 8 months post-injury, and you were to have an image, and they will say, well, I had pain there, and it's kind of come and gone since, and you get an x-ray, what you may see is a big, irregular, hypertrophic ossification. So it'll look like irregular bone. Now, if you don't know about apophysitis, you may be concerned about another bony process. And even on imaging, and Dr. Steiner can comment on that, historically it's been sometimes difficult with chronic apophysitis to differentiate between normal bone and an abnormal growth. Is that still the issue with?
Yeah, absolutely. That's when we start, that's absolutely right. But that's when we start getting the referrals for malignancy. Families come in completely panicked, and it turns out to be something very simple like apophysitis, or a healing one at least.
Yeah, here's a great example of one here. So what Dr. Stein was talking about, this is an old hamstring strain. This is the ischial tuberosity on the right we're looking at, and you can see that just doesn't have a normal appearance. The cortex is not intact, and on the right, that's what the cortex should look like. Okay, it's nice and smooth. And when we take a look on that right side, you can see how irregular it is. You might even think it may even have a little bit of an eroded appearance. And this is why it's so important to have awareness of these injuries, that you can then ask the athlete, do you remember having a hamstring injury 3 months ago, 4 months ago? And so, oh yeah, it was about 5 or 6 weeks before I could get back to gymnastics or figure skating, or etc. Here on the top left here, this is what I was talking about, the Rister's lines, the iliac crest. The injury again is on the left side. You can see this normal physis here between the iliac crest on the right. If you follow physis along, you see a separation, and if you actually measure that, you can see a slight increase to distance in the anterior iliac crest apophysis. And this was a cross-country runner who was having 3 months of left hip pain. Okay, once again, how easy is it to palpate the iliac crest? Very, very easy. So now that you're aware, these are things that you can examine. This was a calcaneal, there's apophysitis, there's severs. Here on this particular one, on the top left, okay, once again, you can take a look at, this is an MRI. On the right side, you'll see the pubis come in. You can see increased edema on the left. This was a pubic tubercle apophysitis, okay. I'm just going to show one more because this one's a common one that you'll see on the bottom. So make sure bottom left. Okay, this is a coronal MRI. Okay, Classic of these is soccer athletes say, I went to kick the ball and I felt a pop. And you'll examine their hip, you can range their hip, and it doesn't cause any pain at all. As soon as you press at the front of the hip, right over their anterior iliac spine, it will be sore. This is a right hip injury. You can see on the left the iliac crest going down towards the anterior iliac spine, and there's no increased bony edema. When you take a look at the right, you can see that increased edema there, specifically at the anterior inferior iliac spine. Once again, you get an x-ray of this patient in 10, 15 years' time, they'll have a big irregular bump in that area because of the healing that's occurred. So once again, it's important to be aware of what these injuries are. Okay. So with an apophysis, you're getting this increased osteoblastic activity, you're getting edema, there's a proliferation of a combination of spindle cells and these intratrabecular spaces with some inflammatory cell infiltration. But the main thing is that in a chronic situation, you kind of want to manage the load. If it's really flared up and it's preventing them from doing the activity, you want to hold them back. And if it's feeling better, then you can essentially get them to engage the activity. However, in an acute avulsion situation, you'll see this in the literature that we present in a second, you really want to essentially protect that for a minimum of about 6 weeks. You're treating it as like any other avulsion fracture. So, these are extremely common in growing athletes, okay? They're not well understood and well appreciated in terms of a community care of the childhood athlete, and I want this to be the main take home today from this talk. And once again, keeping in mind that these healing apophyseal avulsion injuries may mimic bone tumors. We're going to take a look at a study now. This is a study that was done specifically on soccer players. It's a Doha Academy study. They did over 4 years, looked at 550 athletes, okay, between U9 and U19. 84% of the injuries were apophyseal injuries. And this is much more in keeping with what we see in the sports practice with the child athlete. Not only that, if we take a look at the time loss, okay, so per group, they measured almost like as a team loss. So per squad of 25 athletes, you're looking at almost 3 months of lost time due to these apophyseal injuries. So this speaks to the sports specialization that we talked about in the morning. This is how much load is going on to these kids that we're losing this amount of time, but also these aren't really injuries that we should be ignoring or mischaracterizing as muscle injuries and saying, oh, you'll be back in 5 to 7 days. Next, we're going to talk about the physis injury, the growth plate injuries, okay? These can happen acutely with respect to your Salter-Harris injuries, 3, 4, 5, but they can also happen due to repetitive compression. So if we think about, for example, our slip capital femoral epiphysis, gymnast wrist is another one. Now, the proximal humeral physiolitis, this is your little leaguer shoulder. Technically, it's a rotational shearing force that's happening in the external rotation phase of the arm that's causing it. But regardless of which, these are all injuries that occur to the physis. And one of the things I would recommend, similar to what we saw previously with the avascular necrosis and navicular, as a clinician, if you're having difficulty in looking at the imaging and you want to help both yourself and the radiologist, and Dr. Steinbeck can comment on this, one of the things that's helpful specifically in these is to get bilateral images so that you can compare essentially the normal side to the affected side, and you can actually measure the distance of the physis, which typically is essentially increased in the little leaguer shoulder, but also then we will see the changes. I think I have an x-ray of the subcapital femoral epiphysis in the next slide. Yes, I do. So in the middle here, this is a physis injury on the left side. Skiffies, they may refer, and this is the other tricky thing. So we talked already, children having difficulty communicating necessarily what exactly the issue is, but also it doesn't help that these don't refer necessarily locally. So a skiffy, it's not uncommon for a child to complain of distal thigh pain or knee pain. But what's going to be helpful from your end is you're going to examine that knee, and when you see that the knee is normal, We examine the joint above and examine the joint below. When you go to examine the hip, it's going to reproduce the pain. This is different from the apophysitis. So when we put our thumb over the anterior hip spine and it reproduces the pain, here, and then we can range the joint in an apophysitis, here, as soon as you go to range the joint, it's going to cause their pain. And you can see on the left, you can see the physis, and the femoral head is essentially dissociated from the physis as well as the metaphysis of the femoral neck there. On the left, this is the little leaguer shoulder. This is what I was talking about. I've stitched these together. This was a left and right x-ray. This is a right-handed picture. They had about 3 months of right shoulder pain. You can see the physis comes across as an S there on the left. If you just have the x-ray on the right, it may very well be read as normal, but when they can compare it to the other side, we can measure those distances, and it's very helpful diagnostically. So from the physis pathology perspective, so we're talking about our slip femoral epiphysis or little leaguer shoulder. Generally what ends up happening is you get a rotational or compression force that leads to that translation on the growth plate, and that's a very, very, very highly active zone, and there's loads of blood vessels going in it, those get disrupted, and that's when you start to get that necrosis or breakdown. And that's why, once again, we're not looking for injections in these situations. We're looking, this is a significant issue if a child's having bony pain, that we need to look at modifying their activity and obviously protecting that part of the either joint or bone. This is just to highlight earlier. Remember we talked about the difference relative to age and the closing of growth plates. This is a large table, but what all this is, it's taking a look at MRIs done of athletes adolescents between 14 and 21, and they took sequentially MRIs annually to see when the growth plates closed. And you can see that, essentially less than 16 across the board for males, you're looking at less than 50% have closed growth plates, with the exception of the distal tibia. Now, if we go across here and we look at females, you'll see that over 70% for the most part, apart from the radius, the growth plates are closed. And now there's variation within that, but it just goes to show that you can't treat every 14-year-old like a 14-year-old. And so you have to treat the individual athlete based on their stage of growth, and that's why the assessment is very important. Dr. Wynn has left, but one of the things that, having assisted him for a number of years, is that we've seen growth plates open when drilling for your ACL tunnels up to age 25. So, even this, you've got to keep in mind there's other things, and like Dr. Goulet was mentioning, when we're talking about concussion, there's other things that can be going on underneath. So you might want to be aware if there's a child that's having difficulties with a joint, that there may be something else going on. For example, a skiffy, you might want to be thinking about thyroid issues, or if there's repetitive stress fractures like Dr. Steinbeck talked about, maybe considering other things like underlying osteoporosis. Metaphysis injuries. So once again, the anatomy approach here is very important. You've got a child coming in, let's say they've had a fall, let's say they got tackled, they've got bony tenderness. This anatomy approach is going to help you when you go to take that image to take a look where you're going to look at on the x-ray. There is a traction injury that can happen, both acutely or chronically, to the metaphysis. We're going to take a look at both of those in a second. First one are the torus. These are the buccal fractures. Some of these are very easy to see, like for example here on your left, this is a buccal fracture. If you follow the cortex, you'll see this bump here. It's a compressive injury to one side of the cortex, okay? These are very, very stable injuries, okay? But it just goes to show, there's something to take a look at the x-ray, take a look at that metaphysis. Once again, this is a very soft area in children's bones that can get affected. And when we think of, the antalgic gait in a child, you should also be looking for torus fractures, because these can happen in the long bones. So just like the tibia. So if we take a look here on, this is a toddler, I can't remember what age they were, less than 2, I think. And they had a torus fracture of their distal tibia. And this one here is a torus fracture of the sternum. This is a gymnast and a trampoline athlete. So if we follow the sternum up here, the middle portion of sternum, keep in mind sternum develops in 3 different bones. The middle bone here, if you follow the external cortex, you're going to see a step there. And that is actually a compressive force. So that's not actually a force directly to the chest. That is for compression in terms of a hyperflexion of the trunk that occurs. Once again, these are things that you can palpate on examination. This is somebody that got sent to the emergency department because of chest pain. Before I even saw them, they had a cardiac workup, a chest x-ray, they had a troponin drawn, ECG, and this is something that was like 2 weeks old and it was getting better, and you could see the swelling, it was warm, and you could palpate it. Now the x-ray obviously helps with the diagnosis, but just gives you an idea, once again, using this anatomy-based approach is helpful from a diagnosis perspective. There is a rare injury that we will see in sports clinic, which is called a cortical desmoid or tug injury. You can see acutely. There's one off the medial metaphysis of the femur associated with your adductor magnus. You can see skiing is a common one where essentially the leg gets pulled due to slipping on ice, and they'll feel either a pulling sensation or sometimes a pop immediately. They'll be very, very tender. It's deep. It's kind of deep to palpation, but sometimes they'll have difficulty walking. Their knee examination, again, will be normal. Okay, so you can range their joint. They're going to be stable, but when you do an x-ray, what you see on the top left here, just as I circle it here, you'll see a little bit of exophytosis of the bone there, and that's where the adductor magnus essentially attaches onto. This one here is in your leg. This is another type of a cortical desmoid or tug. So this one's going to be a hard one to diagnose clinically because it's associated with your soleus. So the soleal line, the posterior tibia where the soleus attaches, as well as the posterior fibula, that gets pulled. These tend to be a little bit more chronic, giving that kind of appearance of the periosteum being essentially drawn off the bone. So these tend to be a little bit more chronic, just based on the amount of tissue involved in terms of attached to the bone. The diaphyseal injuries, the shaft injuries, these are fairly straightforward. These are typically, you're not going to see them in the sports clinic, but obviously these can occur as well, just further highlighting one, a compression injury, but two, the softness of the bone. So, in terms of the clinical approach, once again, that history is going to be very important. Is this an acute injury or is this a chronic injury? And two, are we talking about compression forces or traction forces? Okay, so in a situation where you're dealing with an apophysis, those are going to be your traction injuries. So somebody coming in, for example, with 3-6 months of heel pain in a 10-year-old, and they're tender right at the back of the calcaneal apophysis, that's going to be a chronic traction injury. That's essentially when they're landing from running repetitively. And whereas, somebody coming in and having an antalgic gait, you go to examine the joint and the hip sore, that's more of a compression injury and you're concerned about the actual joint itself. So noticing between traction and compression, that's going to help you. And then secondly, the examination. So is the pain localized versus non-localized? So a couple of things that are also helpful, I use all the time in assessing pediatric patients, especially because they have difficulty understanding how to describe things, but also the parents are often hands-offish or overprotective of you examining the child, is just gently putting their hand over, checking for warmth or swelling, okay? Because if there's an underlying fracture, those two things are almost always common. The next thing is determining whether the pain is localized. So if they're able to essentially point where exactly the pain is, that's classic of apophysitis. Those are very well localized, okay? And once again, apart from the lesser trochanter in the lower limb, they're almost all easily palpable. So then that's going to guide us to our next step. So if we're still not quite sure, what are we going to do from our next step in investigation perspective? So if it's localized and it's not near a bone, we may consider it an older athlete that's muscle tender. We can consider doing ultrasound. However, if they're tender on the bone, then we want to do an x-ray. And I know we talked about radiation, but what I'm going to tell you today is that it's more likely to have a bony-related injury in a child doing lots of activity than it is a muscle tendon injury. So don't be afraid of ordering an X-ray if you're having difficulty with the diagnosis of a child who's continuing to have pain in sport. And then this is just kind of a bigger breakout as to what we can see with this imaging. So, from an X-ray, when we saw Dr. Steinbeck's talk, she talked about when we do a series of knee X-rays. So you can do an AP and a lateral, but if we do something called a tunnel view or take a look at the notch view, that really gives us a better indication of what the condyles look like, okay? To check for things like osteochondrosis dissecans. X-ray can show obviously rare things like tumors. It can show your Salter-Harris fractures. Sometimes it can show your stress fractures and other things like the cortical desmoid that we talked about before. Now, if you have an abnormal joint examination, and let's say the X-ray is normal, this to me would be an indication to consider further imaging such as an MRI, okay? If a child can't move a joint, okay, you really want to be taking a look at that further. If you can't move, specifically if you can't move the child's joint, so you try and do it passively, that's an indication that there's a problem in the joint and you need to be taking a further look. Once again, with a normal X-ray, that could still be osteochondritis dissecans. It could be, a JIA. It could be another type of cartilage injury, such as like a meniscal tear or underlying ligamentous injury. Long term. So we talked about sports specialization. We talked about the effect it can have on mental health, the effect it can have on families, the costs, okay? But there's also some specific health considerations that we need to consider. So, in terms of compression injuries, for example, if we take a look at a vascular necrosis of the hip in a Perthes specific, half those patients are going to have pain and disability in their 40s, okay? So the next thing I was going to talk about in relation to this, we had a talk about from Dr. Francello about spondylosis and spondylolisthesis. If you take a look at MRIs of athletes in their 20s, over 75% of them will have facet arthropathy. Asymptomatic. Where is that coming from? This is coming from the overload from sports. And I think this is something that we have to be aware of, is that we may actually be guiding essentially earlier arthritis from the overload that we are encouraging in the current sport culture. Apophysitis, these are also things that can lead to issues. So Dr. Steiner talked about what happens with the patellar sleeve that can heal into a banana-shaped like bone. Same thing with untreated osteochondrosis. If the athlete pushes through, that tibial tuberosity can actually traction towards the joint, and you can lead to some anterior impingement and increased patellofemoral pain syndromes in an adult population. Also, that tibial tuberosity protrusion can lead to soft tissue irritation. So you may have adults that have Osgood-Schlatter's. That inflammation is likely related to the irregular bone that's underneath that's getting traction, or they're more likely to kneel on it and cause essentially compression injuries as a result, as opposed to them having an active tibial tuberosity apophysitis. And once again, those imaging abnormalities will last a lifetime. So these are things to be aware of. Now you're going to take a look at X-rays of adults, and you'll see these abnormalities, and it's likely they had an apophyseal injury previously. Once again, there's inconsistent literature and very sparse on the natural history of how long these injuries last. So, the recommendations from this anatomy-based approach is that we can better define things so we can improve these epidemiological studies so we get a better natural history, considering both age or age categories within these studies, better define the terminology so we're not using terms that cross over, being aware of that apophyseal injury, the apophysitis, as being a common injury in the growing athlete, and to check for that bony tenderness, and then finally to consider bilateral imaging in situations where you have a child with tender bones and you're looking for extra help to compare it. Thank you very much.
Yes. So I have had a patient the other week who had really bad sitting Larson-Johansson syndrome. He's 10, but even walking around he was having pain. And I talked to parents about shutting him down, and they weren't really convinced on it. And we kind of talked over like the risks with not only pain he's already in, but the chronic pain and things like that. But was more wondering, is there actual data on the risk that he's progressing to like an avulsion injury from a kind of ignored chronic?
Yeah, so I did in the apophysitis box, I actually took a look at where your avulsions are likely to occur. So as you go distally, they're much less likely to occur. Like I don't think I found a single calcaneal apophyseal. Now this was done maybe 5 years ago, but I didn't see a single avulsion fracture there. Your tuberosity, you can avulse, it's highly likely. You're sending Larson-Johansson, there was no case of that. It'd be highly unlikely. You're more likely in an acute incident to get patellar sleeve disruption. But in terms of the chronicity perspective, that's not really going to separate. That being said, if the child is having difficulty walking, what I often do is I put the question back to them. So what they're doing is they're offloading the situation to you, and I'll say, well, what do you think? Do you think you could play tonight? They know the answer. And when you put it that way, they often sit back and it gives them time to reflect and then the information to set in. And then, advising on a follow-up routine as well as the things they can do. The sitting Larson-Johansson is often related to specifically like kneeling deep squatting. What sport was that child involved in?
He was badminton.
Okay, so deep lunging. Okay. So I mean, if first, I presume the child had an intelligent gait?
Yeah, we did.
A little bit, or they did?
Yeah, we did. Like, he was very, very tender, like everything pretty much for testing and walking. It was a very variable, like when he played, I guess, in a sense. Like, he was doing like over 25 hours a week sport at 10 years old.
So I think one of the things that helps when dealing with both children and more importantly the parents, it's not so much the challenge of you getting the diagnosis, it's the challenge of you getting that across to the parents. And one of the things I will use, similar to what Christian was talking about in terms of concussion, or what we do with patients with back pain, is trying to enable the patient to see what they can do. And so what I'll do in that situation, especially with an intelligent gait, say, Billy, can you get up and walk for us? And I'll say to parents, like, is he walking a bit funny? I know he's walking funny. I know he's limping. They say, yeah, he's been doing that. I said, how has he been doing playing badminton? I said, well, he's not performing as well. And then I will lead all those questions and I'll string them together at the end and say, listen, I'm quite concerned, Billy's limping. You're telling me he's not performing well at badminton. He's got a lot of pain on the exercise. What do you think about like taking a break so we can get this to calm down so we can do all these activities without limping, without having pain? And when you frame it that way, more often than not, you're going to get better buy-in than essentially presenting the diagnosis, because the diagnosis is not the problem here, as you're seeing. You're dealing with 3 patients, not 1. That's what the difficulty is. And so you're trying to essentially build that narrative so that everybody's on board.
Yeah, I think the most they would agree to is like a 50% reduction.
Sometimes you take all of them you can get. Sometimes what happens is that's the compromise.
Yeah.
And in those situations, I recommend a closer follow-up. How's that going?
Would you track X-rays or anything? Like if it's continuing at that level, regardless of the pain, is there any point in tracking repetitive X-rays of the knees, for example, and seeing that kind of?
So I don't think you're going to, Dr. Sandberg, comment. I don't think you're going to see much from a Cindy Larson-Johansson. Now, caveat being, you want to make sure there's no joint effusion, that joint is stable, there's no joint line tenderness elsewhere. Given that the knee's stable and I can range it fine, then you can continue to just follow that up clinically. In terms of routine X-ray, you're not going to see much. If you were to do an MRI, you're going to see some edema. But once again, that's not going to help you apart from you already clinically know that he's limping. And
Yeah. I was wondering where it would disappear, if there was like a little bit of worsening potentially, on imaging wise.
I think you're going to have the same issue at that stage if you had that MRI image up and the bony edema, and you're probably going to have the same difficulty. It's not, once again, it's not the diagnosis. You're thinking of the diagnosis as the problem. It's the desire to continue the sport and continue pushing forward. That's number one. It's why is this holding them up, right? So then you've got to buy that. You've got to rearrange your puzzle pieces to get them to understand the other pieces that are involved. And that's why I said, that's why you feed back all the things that they've fed to you, and then they're hearing it back. So it's kind of they're hearing it the second time.